I'm just generating the YouTube link. So, good evening to all the participants, all the respected dignitaries who are joining us today for this great session. I welcome you all on the behalf of Team Physio Inculcator in the today's webinar on a great topic by a very great resource person, spinal cord injury, its assessment and its associated comorbidities. We would be going to have a great learning ahead today in this session. We also have a feedback link. Feedback form would be available to you all in the chat box after 35 or 40 minutes of the webinar. So I would request to all the participants, please spare some time to fill a short survey, a short feedback form, though we can have a, motivation and improvements as well. Kindly be patient as there are a lot of participants available in the waiting room. Just within a minute, I'm going to make it live on the YouTube, and I'll provide the link in the chat box also. If any of your colleague or friend wishes to attend, kindly share that YouTube link with that participant, though they can also join the session. Within a minute, I'm going to share the link. It is just because of aura of the talk and aura of the resource person that we have so much participants for this session. Even though as of now there are lots of webinar going on, still around above 100 participants are joining us. It definitely indicates the aura of our today's resource person, Professor Irshad sir, and the topic. And it is just because of their teachings and their expertise on the talk that we have a lot of participants. Just copying the YouTube link and then providing it to the link is available in the chat box here. So if any of your friends or colleagues wishes to join, kindly do share the link, though they can also join the session before starting, though they can join from starting of the session. Please take a minute to share this link because around 15 more participants are there outside in the waiting area. So few I'll allow in the Zoom, but few needs to be joined from the YouTube. So just a minute last. I'm just sharing the YouTube link. Thanks for being so patient and really thankful to the Irshad sir for being so patient with us. So, with your kind permission, shall I go ahead with the introduction, sir?
Sure, please.
Thank you, sir. Thanks a lot. So, hello, good evening, you all. Thanking you all for being patient and being connected with us for this today's great talk by a very great, a renowned resource person, Professor Irshad Qureshi, sir, with us. Irshad, sir, has done their post graduation in the neurology in 2005, and he has around more than 15 years of the teaching as well as clinical experience. Professor Irshad sir is currently working as a Dean Academics in the Faculty of Physical Therapy, Datta Mega Institute of Medical Sciences, Wardha, Maharashtra. He is also working as a Vice Dean of the Academics in the Faculty of Physical Therapy, Datta Mega Institute of the Medical Sciences, Wardha. He is a professor and head of department of the Neurophysical Therapy in the Ravi Nair Physiotherapy College, DMIMS, Wardha, and Dr. Irshad sir has received numerous prestigious awards for their outstanding contribution towards the profession and professional upgradation. He has published lots of papers in the Journal of the International Repute, and he has been published around more than 15 research papers and still in the process of publishing the papers of around about 10 articles, and he has been awarded by a Swabhiman Samman Award by IAPMP in the Physio conference of the IAPMP Bhopal, and is also a member of Board of Examination, Board of Studies, Internal Complaint Committee, Institutional Ethics Committee, and University Annual Report Committee for the Datta Mega Institute of Medical Sciences, Maharashtra. Is also a permanent invited member of the Board of Management, IQAC, Academic Council for the Datta Mega Institute of Medical Sciences, Maharashtra. And he has been invited in the numerous national as well as international conferences for as a resource person for presenting their expert talk. So we are really delighted and honored to have Irshad Qureshi sir with us here, as sir is having very much busy schedule in their academics. Still they have spared the time to share their incredible knowledge with us on the board. We are really grateful to you, sir, and please apologize for any mistake if I have made, as your name is itself enough and for the introduction, but still I tried my best, and if I have done some mistake, please forgive. And I would like to welcome you, sir, from the core of my heart. Welcome you on the board, and also welcome to all the participants, senior dignitaries, academicians, and researchers who has joined us for this great session. And for your information, sir, we are having participants here from around 5 countries for your talk, and many more are even in waiting. So again, welcome to you, sir, on the board. And now stage is all yours, sir. Thanking you, sir. Over to you,
Thank you
sir.
very much. Thank you very much. Thank you. Senior dignitaries, my respected teachers, my seniors, my colleagues, friends, loving undergraduate, postgraduate students, I welcome you all. First of all, I thank you all for sparing time for this knowledge sharing session on neurological complications, associated conditions, and assessment of spinal cord injury. Though this is something like a very common clinical condition, which is like more associated with the physiotherapist. Very frequently, we encounter with patients having spinal cord injury. We have studied in undergraduate and postgraduate level various impairments, complications, associated conditions, secondary complications, and their assessment also. But with the time, if you don't look after your patients and if the time goes off, then certain things which are very common, but it fades from the mind and it goes out of your knowledge. So before I proceed, it's my salutation to my parents and teachers. This wouldn't have been possible for me to share this platform for knowledge sharing session. My introduction has been already been provided by Dr. Himanshu. This is a small quotation. Before starting our session, I would like to share with my students who are in the process of or journey of their learning. So have this as a positive attitude or positive impact on your learning process. And I would love to share this pyramid, which is called as a learning pyramid. And you can see the knowledge retention rates. So if you see, this has been divided into two major parts, that is your passive teaching method and participatory teaching methods. So what is the conservative methods of our didactic teaching? Reading, audiovisual demonstrations. So maximum retention of knowledge goes to 30% if it's a passive teaching method. If it's a participatory teaching method, maximum learning goes to 90% for a method which is called as teaching to others. So I'm here on this platform to share my knowledge and pyramid on the background so that we can make others understand. Very helpful and highly beneficial to you in the retention of your knowledge. So if you want to retain your knowledge, prefer to teach others. And rather, I would make a correction into this. I should say, prefer to make stand. Understanding can be, you can make your patient understand, you can make your family, friends, relatives understand. So if you're making somebody understand your knowledge, then you are making your learning more retentive and your knowledge is being more polished. So with this prologue, I'd like to begin my today's topic. That is a small background I have prepared onto the procedure, even though this is not the part of actual session. But if we don't provide the small feedback about this spinal cord injury, then this will be little like a missing component it will be. So it is basically divided into two categories, that is traumatic injuries and non-traumatic damage. I would like to have your attention. The first term is your injuries, that is traumatic injuries, and second term is damage rather than injuries. So non-traumatic damages are there and traumatic injuries are there. So major causes of your traumatic injuries are motor vehicle accidents, fall, violence, and sports injuries. Among them, the most common one is your motor vehicle accidents or road traffic accidents. And later on, the fall common, which is 7.9%, violence 3%, sports injuries are 8%. There are lots which include the dysfunction like AVM, arteriovenous malformation, thrombosis, embolism, hemorrhages, vertebral subluxation, neoplasm, syringomyelia, abscess of spinal cord, infections like syphilis and transversalitis, and neurological disorders like very common diseases, multiple sclerosis and amyotrophic sclerosis, lateral sclerosis. These are the commonest non-traumatic reasons for spinal cord damage. And non-traumatic etiologies account for approximately 39% of all SCIs, spinal cord injury. 56% of spinal cord injury experience cervical region results into the tetraplegia, and 43% of spinal cord results into paraplegia from thoracic, lumbar, or sacral injuries or lesions. Incomplete injuries results in tetraplegia, that is or also called as a quadriplegia, that is almost like 40%. Complete paraplegia goes to around 22%, incomplete paraplegia 21%, and complete tetraplegia it's 16.3%. So you can, with these figures, you can find out like incomplete injuries resulting into tetraplegia and complete paraplegia where there is a lot of scope. Incomplete paraplegia, complete paraplegia, and incomplete quadriplegia, there are a lot of scope for rehabilitation. So being a physiotherapist, this figure gives you a huge background that provides that provides us a scope for rehabilitation. Then broadly, classification. This is classified into two functional categories, that is quadriplegia or tetraplegia and paraplegia. We all know that tetraplegia refers to the complete paralysis of all four extremities, trunk, including respiratory muscles, and this results from lesions of cervical cord. So cervical cord means up to the brachial plexus, which is up to thoracic 1 level. So lesion up to this level will result into quadriplegia, and paraplegia. This refers to the complete paralysis of all or part of the trunk and both lower extremities, resulting from lesions of the thoracic, lumbar spinal cord, or cord equina. So here, this is not actually mentioned over here, but the paraplegia, even that is further subdivided into high paraplegia and low paraplegia. High paraplegia, where there is a involvement of the injury at the thoracic level, resulting into bilateral lower extremity paralysis as well as some respiratory compromises. Whereas lower spine, that is your lumbar spine, uh, which is getting injured, affected at this level and resulting into bilateral lower extremity paralysis, results into low paraplegia. I'm not going to talk a lot about these clinical syndromes, like we all are aware of them. Brown Sequard syndrome, anterior cord syndrome, central cord syndrome, posterior column affection, and cord equina. Basically, I would like to take your attention onto the term which is syndrome. Syndrome means this is a collection of multiple symptoms. So if you talk about Brown Sequard syndrome, anterior cord syndrome, so basically this is a typical type of injury resulting into collective symptoms or features which is very specific to the specific type of spinal cord injury. Like if you talk about Brown Sequard syndrome, so in other terms, you can call it as a hemi-transection of the spinal cord, half side injury of the spinal cord, which actually results from like a gunshot injury or stab wound injury. So this is a typical type of trauma resulting in the spinal cord damage. And if you talk about the syndrome, then if you take the example of Brown Sequard syndrome or hemi-transection of the spinal cord, this is going to have a very typical presentation or typical symptoms carrying with this. So so this term basically syndromes is a collection of symptoms. So depending upon to the type of injury like flexion injury, extension injury, or some traumatic, non-traumatic reason resulting into various types of syndromes. So this was the prologue about the spinal cord injury, traumatic and non-traumatic reason. I'm going to begin with the first part of our today's session, your neurological complication associated conditions. So spinal cord injury results in a disruption of communication from higher centers in a central nervous system to the periphery. And this disruption results in loss of sensory function as well as impaired autonomic function. So what we can see being a physiotherapist, the most visible component of impairment is motor function, because the patient experiences, we can see, we can assess very nicely. A hidden component which is complained by patient, that is the sensory function. Patient says I don't feel anything, and very notorious character which acts behind the screen is your impairment of autonomic function. So this has a very huge role impact, as well as at certain aspects you can call it, this is very dangerous, fatal also. So we are going to talk about this in the later slides. First, we are going to talk about spinal shock. Everyone knows from the third year, we start talking about this in the clinical subjects, spinal shock or any of the cerebral shock. So stage of shock is basically, for the spinal I'm saying, there is a period of areflexia, which is a part of the spinal shock. And the cause behind this is abrupt withdrawal of connections between the higher centers and spinal cord. This is actually characterized absence or reflexive activity, impairment of autonomic regulation resulting into hypotension, and loss of control of sweating and piloerection. There is going to have loss of all the reflexive activity. So all reflexive activity will include your all deep tendon reflexes, loss of ergocavernosus reflex, rheumatic reflex, Babinski response, and plantar response. always remember, if you're talking about the characteristics or presentation of spinal shock, then the typical presentation is going to be the below the level of injury or below the level of trauma. The physiotherapists, we are more concerned with motor impairments, motor presentation. We talk about hypotonicity, lots of talks goes on to the tone, reflexes, uh, superficial reflexes, deep tendon reflexes. But there are certain characteristics which are not very commonly discussed by all, which is a part of spinal shock. So hypotension or decreased cardiac output is one of the characteristics of spinal shock. Bradycardia, hypothermia, vampirism, ventilatory impairment, bladder flaccidity, paralysis of peristalsis. All these are the typical characteristics of spinal shock. I have selected the exclusive one, which are very common and which can be seen or experienced most commonly. And there are a lot many more characteristics of the spinal shock. There are certain stages, a total phase of areflexia, which lasts approximately 24 hours theoretically, but it can last up to 72 hours. At times, this has been seen in lasting for a week also, which is followed by gradual return of reflexes, like it occurs within 1 to 3 days post injury, and this may occur up to 1 week also. As soon as the stage of areflexia resolves, then it will follow gradual return of reflexes. A period of increasing hyperreflexia lasting for 1 to 4 weeks. So once there is a return of reflexes, this is going to keep on increasing gradually for 1 to 4 weeks. And final stage of hyperreflexia, this is going to last for 1 to 6 months after injury. A plateau may occur within a year, or it may occur up to 1 year also. So this is going to be the very bothersome, most bothersome problem you can say in your. If you talk about the rehabilitation aspect, hyperreflexia, hypertonicity, this bothers us a lot. Being a physiotherapist, this is a major barrier you can say, but there are certain benefits of it also. Motor and sensory impairments following spinal cord injury, there will be either complete, that is your paralysis, or partial, that is paralysis, loss of muscle function below the level of lesion. Always remember, whatever is going to occur is going to occur below the level of lesion. Disruption of ascending sensory fibers following spinal cord injury results in impaired or absent sensation below the level of lesion. And the clinical presentation of motor impairment depends on the specific feature of lesion. This includes the neurological level and the completeness of the lesion. So what I had discussed in the beginning, that is your syndromes or clinical presentations. So it depends, the clinical presentation of motor and sensory impairment depends upon the what type of injury it is and what is the cause behind the injury. Say for it's a dashboard injury, head-on collision, hit from the back, fall from the height. So these are the typical reasons which are going to result into a specific type of syndrome. So clinical presentation of motor and sensory functions are going to depend onto the mode of injury and resultant spinal cord damage. We are going to discuss the most notorious impairment, you can say, after a spinal cord injury, that is autonomic dysreflexia or autonomic hyperreflexia. This occurs in the lesion above T6. It may occur at the level of T6 also. At times, it may occur below the level of T6 lesion also. But the most common one is above T6 lesion. Acute onset of autonomic activity from the noxious stimuli below the level of lesion. I have highlighted, underlined that noxious stimuli. So we are going to talk about that later. It's a critical emergency owing to the lack of inhibition from the higher center. Hypertension triggered by autonomic dysreflexia can result into seizures, cardiac arrest, subarachnoid hemorrhage, stroke, even death also. In the beginning, what I said, autonomic impairment is a silent killer. So we are going to talk about this. Initial stimuli for autonomic dysreflexia. Its most common cause for this pathologic reflex is a bladder and bowel distension or irritation. I repeat, the most common cause of this pathological reflex is bladder and bowel distension or irritation. So you can imagine how parallel cause goes with our spinal cord injury, because they are going to have catheterization, indwelling. There are a lot of chances of kinking, blockage, and this cause parallelly runs with each and every patient, each and every moment. The common bladder issues that may trigger autonomic dysreflexia are central bladder block catheter urinary tract infection, renal stones, irritation of bladder or urethra during the catheterization or during the other procedures also. Precipitating stimuli, pressure source, which is very common with spinal cord injury, uh, noxious cutaneous stimuli below the level of lesion, kidney malfunction, electrical stimulation. Physiotherapists, we very commonly prefer to have this electrical stimulation below the level of lesion. So, if the patient is complaining of lots of pain, which is like neurogenic in nature, and we very innocently we may prefer to go ahead with certain type of electrical stimulation or transcutaneous electrical nerve stimulation, TENS and all that, which is the most preferred modality for pain management. So be very cautious. Be very cautious, especially for the students who are at the learning stage and those who have not yet been exposed to the spinal cord injury patients, and prefer those who prefer to have electrical modality in upper motor neuron lesion. There is going to be a sexual activity which acts as a precipitating stimuli, and skeletal fracture below the level of lesion, which usually occurs in the road traffic accidents or during the act of violence. This is a common one associated stimuli along with the spinal cord injury. What are the symptoms of autonomic dysreflexia? They're going to have hypertension, bradycardia, headache, which is very severe and pounding, profuse sweating, restless constriction below the level of lesion, vasodilatation above the level of lesion, and constricted pupils, nasal congestion, pyeloerection, and blurred vision. So, out of these symptoms, what is visible and what is invisible? The patient may complain of severe and pounding headache, profuse sweating, increased spasticity. So, this is evident. You can see the spasticity, increasing spasticity with the spinal cord injury patient. There is going to have very typical pattern with increased tone, restlessness. This is what you can see. So there are certain symptoms which are actually eye-catchy. You can observe them. There is going to have nasal congestion. You can, while talking to your patient, you can feel it that all of a sudden something going wrong. So if you keep these symptoms in the mind, then you can catch it early. Increasing the systemic blood pressure to 30 mm of mercury is diagnostic of an episode of autonomic dysreflexia. 90 to 110 mm of mercury for those with a neurological level above T6 lesion. Systolic blood pressure may rise up to 250 to 300 mm of mercury, and diastolic may rise up to 200 to 220. So here you can see if the blood pressure is rising like a 250 to 300, 200 to 220 mm diastolic, then you can imagine how fatal this condition is. Anytime the patient may have stroke, anytime your patient may have a cardiac arrest. So it's the you can initially what I had discussed, like what is the precipitating factor or what runs parallel with our patient, that is your bladder distension and irritation, and this may occur if the catheter is blocked, if the catheter is kinked, bladder is keep on distending, and this is going to act as a stimulus, or later on the patient may have all the symptoms, which is quite fatal. Onset of symptoms should be as a medical emergency. If the patient is lying flat, the patient should be brought to the upright position. Loosen any tight clothing. Blood pressure and pulse to be monitored. The individual should be questioned as to the possible triggers, starting with it actually runs parallel to the autonomic dysreflexia irritation of bladder. So bladder and bowel should be examined first, especially the bladder one. Examine for triggering stimuli such as tight clothing, restricting catheter straps, abdominal binder, or anything that may be noxious in nature. So, being a physiotherapist, at times during the rehabilitation, we apply abdominal binders as well as lots of orthoses are also provided for the paraplegic patients like HKFO and all that. So, any of the things can be acting as an noxious stimuli during the episode. So everything which could result into stimulus should be removed and taken care of. The pharmacological intervention may be required to lower the blood pressure. The second, third one actually, this is third impairment. Initially, I shared the most bothersome of patient cord injury. Lots and lots of energy is being consumed to take care of the patient having the spasticity. 65% the syndrome means there must be some set of symptoms. So there are going to be like upper motor neuron syndrome, includes spasticity, muscle spasm, abnormally high muscle tone, hyperactive stress reflex, and clonus. Spastic hypertonia typically emerges below the level of vision after spinal shock evolve. It goes off. The various stimuli, including positional changes, cutaneous stimuli, environmental temperature, tight clothing, bladder and renal stones, fecal infarction, catheter blockage, urinary tract infection, liquid ulcer, emotional stresses, they may trigger or increase the spasticity and muscle spasm. So everything, there are so many factors which may like act as a stimulus for or precipitate the spasticity. So everything should be taken care once you are taking care of patient having the spinal cord injury. The list is very huge. There is going to have a cardiovascular impairment. Cardiovascular function is regulated by the brainstem and hypothalamus by the sympathetic and parasympathetic nervous system. Cardiovascular function is regulated by the brainstem and hypothalamus by the sympathetic and parasympathetic nervous system. Parasympathetic, basically, this signals to heart arise from the vagus nerve, and this decreases the heart rate and contractility. So vice versa, there is going to have a some kind of opposite function from the sympathetic system. So sympathetic input comes from the spinal segment thoracic 1 to lumbar 2, thoracic 1 to second lumbar vertebra, through the sympathetic trunk, which runs parallel to the spinal cord, and sympathetic input increases heart rate and contractility and peripheral vasoconstriction. So one system acts onto the heart and resulting into reduction in the heart rate, and one system acts onto the heart resulting into increased heart rate. So if there is any injury to the spinal cord and one input is not going to be going to the heart, then there is going to be some kind of imbalance will be the resultant. So spinal cord injury results loss of sympathetic communication, because the injury which is at the level of thoracic and lumbar region may result into loss of sympathetic communication between the brainstem and heart, and while parasympathetic input remains intact because it is coming from the higher center, this causes bradycardia and dilatation of the peripheral vasculature below the level of vision. So if there is a bradycardia and dilatation of the peripheral vasculatures, the resultant is going to be little bothersome. The bothering problem is your orthostatic hypotension or postural hypotension. Lack of or decrease in the active muscle contraction for long time in the bed, this is going to be the resultant. Your hypotension or orthostatic hypotension, which is often experienced during the early position or sitting to other position like high sitting positions. There is going to have some symptoms like blurred vision, ringing in the ears, headedness, and fainting. Cardiovascular system should be allowed to adapt gradually by slow progression to the vertical position. Yes.
Excuse me, sir. Sorry to interrupt you, sir. Actually, there is some
Yes.
voice break is coming. If see if you can do something with the network issue.
Okay, let me see.
Now it is fine, sir.
Is it fine?
No, sir. Now again it is breaking.
Am I audible?
Yes, sir. Again the voice is breaking.
Let me check out.
Okay, sir. Please, sir.
Just hold on for a while. I just switch off the video because this consumes. I stopped my video. I think this will work now because at times this consumes
Okay,
lots
sir.
of data.
Can we remove this tag, sir, on the slide which is available, or it is necessary? Sometimes
What?
it is hiding the words like please move away this window, like the tag I think you have applied on this PPT.
No, I have not actually added.
Okay,
I have not added anything. I don't know why this happened.
okay, okay, sir.
Shall we?
Yes, sir. Yes, sir.
While taking care of the patient having the postural hypotension or orthostatic hypotension, gradual adaptation is the only way to take care of it. As well as later on, you can work or
Excuse me, sir. Screen is only 50% screen is visible. I'm sending you the pic. Above 50 is green, and below 50 we can see the slide. Yeah, now this is okay. Please make it on the full screen again.
can you see
Now it
now?
is absolutely fine, sir. Yes, yes, sir. Please. Sorry for bothering you, sir, and please go ahead. Thank you, sir.
Fine, fine. So while taking care of the patient having a postural hypotension or patient you are expecting to have the postural hypotension, but you take care of the patient right from the beginning, have lots of breathing exercises, preparation for postural adaptation, and then you proceed for verticality or taking the patient onto the vertical position. You can make use of your tilt table also if it is available with the department or in your FD. That is the best way to take care. Along with that, you need to monitor vitals like heart rate, blood pressure, etc. The patient should always be moved very gradually, slowly, and use compressive stockings as well as abdominal binder may further minimize these effects. There is going to have impaired temperature control. Hypothalamus can no longer control the cutaneous blood flow or level of sweating. This autonomic or sympathetic dysfunction results in the loss of internal thermoregulatory responses. The ability to shiver below the level of oxygen is lost. Initially, after injury, hypothermia may occur due to the peripheral vasodilation. Later, the hyperthermia is more likely due to the lack of sympathetic control of the sweating glands. Is going to have pulmonary impairment. Injuries below the E10, that is Qureshi 10, are likely to have near normal ventilation and respiratory function. So we, as well as our patient, is very fortunate enough if they meet some kind of injury which is below the level of Qureshi 10, because they're going to have near normal ventilation as well as respiratory function, because this requires this function requires critical role. This actually plays a critical role during the phase of rehabilitation, vital capacity, ventilatory capacity. Paralysis of the muscle of respiration leads to poor ventilation, which may then cause impaired respiration, leading to atelectasis or pneumonia. Lesions at C1, C2, or phrenic nerve innervation and spontaneous respiration are lost. Breathing pattern is inefficient, requiring more energy to breathe, and as a result of this, the patient may become fatigued very quickly. This is going to have bladder and bowel dysfunction. Patient first we'll discuss about the bladder dysfunction, spinal cord. I think in the previous session by Dr. Suresh sir, this topic has been discussed because he was telling me. So I'm not going to talk a lot about this. Spinal cord injury that alters the complex reflexive or voluntary control of the maturation. As a result, people with spinal cord injury often require a catheter to drain the bladder. Lesions that occur above the conus medullaris and sacral segment develop a spastic or hyperreflexive bladder, that is your human bladder. Following lesion of sacral segment or conus medullaris, a flaccid or reflexive bladder develops. This is also termed as LMN bladder. A spastic or hyperreflexive bladder, that is your upper motor neuron lesion, contracts and reflexively empties in response to a certain level of feeling pressure. The reflex arc is intact. With this type of injury, the detrusor muscle is generally hyperreflexive, and there can be increased tone of the sphincter contraction of detrusor with small urine volume and lack of coordination between the detrusor and sphincters. And this is your S inertia. A flaccid or areflexive bladder, that is element lesion, is essentially flaccid because there is no reflex action of the detrusor muscle. There are generally two types of bladder dysfunction, that is failure to store and failure to empty. Areflexive sphincter or spastic detrusor muscle results into failure of to store, and due to the areflexive bladder or sphincter that is unable to relax results into failure to empty the urine. That is flaccid and invalid catheters. Certain most frequently used method of bladder management is intermittent catheterization, suprapubic tapping. This involves a tapping directly over the bladder with the fingertips, causing reflexive emptying of the bladder. This technique only works for individuals with upper motor neuron bladder without dyssynergia between the detrusor and sphincter. Areflexive bladder can use a Valsalva manner, which may be done by spraining. In the bowel dysfunction, people with spinal cord injury report that bowel function has a greater impact on daily life than any other impairment after spinal cord injury. The type 1, above S2, there is spastic or reflexive bladder, your upper motor neuron lesion. Because the parasympathetic and internal sphincter connections from S2 to S4 are intact, reflex defecation can occur when the rectum fills with the stool. In type 2, S2 to S4 or Cauda peripheral lesion, flaccid or areflexive bowel develops. With an areflexive bladder, the parasympathetic connections from the S2 to S4 are not intact, so the bowel will not reflexively empty. The management, abdominal massage, Valsalva maneuver, diet, appropriate amount of fiber, fluid intake, physical activity, stool softeners, laxatives helps in management of this. Very bothering problem, that is your sexual dysfunction. Spinal cord injury not only affects the physical ability to have intercourse, but also the psychological aspect of the sexuality as well as male responses among the sexual dysfunction. This is the male response. It is directly related to the level and completeness of the injury, broadly divided into upper motor and lower motor neuron lesion. Erectile capacity is greater in upper motor neuron lesion than in the lower motor neuron lesion, greater in complete lesion than in complete lesion. Two types of erections are there, reflexogenic and psychogenic. Basically, the reflexogenic erection occurs in response to the physical stimuli of the genitals or perineum, and psychogenic erection occurs through the cognitive activities such as erotic fantasy. They are mediated from the cerebral cortex. In the female responses, patient with upper motor neuron lesion, the reflex arc remain intact, and therefore the components of the sexual arousal, that is your vaginal lubrication, engorgement of the labia, and clitoral erection, will likely occur through the reflexogenic stimulations, similar to the light responses. And element lesion, psychogenic responses will most likely be present, and reflex responses are lost. Fertility, you can see fertility is not affected as severely in women as the man in spinal cord injury. Menstrual cycle typically is interrupted in first few months, like 4 to 5 months following injury, and later on it comes to the normal, and after this time the normal menstrual cycle returns, and the potential for conception remains unimpaired. This is something like you can see a quite living component. You can see that the potency remains intact. The major considerations for physiotherapists, it is anticipated to have discussion on sexual dysfunction. This is very common because you take care of your patient and you spend a lot of time, patient spends a lot of time with you. So after some time, there may have such a relationship where the patient feels comfortable to have discussion on this topic. The patient questions and issues to be addressed openly and honestly. I repeat, the patient's question and issues should be addressed openly and honestly. The knowledge of referral system or options or supportive services available to the patient for appropriate examination and counseling. You need to have a preparation for this. There are certain secondary complications. I'm not going to talk about this. Pressure ulcers, decubitus ulcer. This is like 36% of the patient during the stay in IPD develops pressure ulcers. So this is quite common. Deep vein thrombosis, another secondary complication, pain, contractures, heterotropic ossification, fractures or osteoporosis resulting into fractures, and seromyelin. These are the commonest secondary complications. For all, especially for the beginners, students who are undergraduate studying the post-graduation, and they are not exposed to the spinal cord injury patients single-handedly. Till now, if you are working under supervision, you need to keep monitoring onto the certain secondary complications as well as primary impairments, what has been discussed in the beginning. So, with this take-home message, always keep autonomic dysreflexia in the mind by taking care of patient with spinal cord injury. Early signs of DVT as well as autonomic dysreflexia shall be treated as a medical emergency. Don't try anything by yourself. This is a medical emergency. We have seen how fatal these conditions are. If your patient is like developing the symptoms of autonomic dysreflexia, we have seen that like hypertension can shoot up to 250 to 300 systolic and 200 to 220 diastolic. This is fatal. No need to just try by yourself. It's a medical emergency. Immediately, you should take care of your patient. The patient should be hospitalized if the patient is at home. If the patient is in your clinic setup where you are taking care of the patient, do not try anything. Immediately shift your patient to hospital. So what precautions or detection of early signs or irritating stimuli, if you can find out, immediately remove it and go ahead with the medical care. Bowel as a sexual dysfunction shall be given equal priority. What happens with the patient? Like we take care of operation aspect, we take care of motor aspect, sensory aspect, but we don't take care of bladder, bowel, and sexual dysfunction. It should be given equal priority. So with this, I'm just finishing up with the part 1, which is your neurological impairments associated with spinal cord injury. The 2 pictures, photographs. Everybody must be like questioning what is relationship of these pictures over here with the patients or assessment of spinal cord injuries. In the first picture, it's a signature shot, and in the second picture, it's a signature event or historic event. If I say Google cricket helicopter, immediately there will have MS Dhoni. If you Google Stuart Broad, Yuvraj Singh, there will have like details of 6 sixes in a row. So this is something like a signature, events, signature shots. So if I show this picture, what comes to your mind? Everybody, like student of 3rd year, 4th year, interns, postgraduate students, professionals, everybody will say assessment of spinal cord injury. This is something like a gold standard. Everyone knows about this, and everybody prefers to use this. Why? Because this is very simple, easy to understand, easy to make use, doesn't consume a lot of time, has lots of advantages. If you take care or if you assess a patient having a spinal cord injury. So this is something like a signature, the spinal cord injury. Asia or American Spinal Injury Association created the international standards for neurological classification for spinal cord injury, that is ISNC SCI. And this provides a standardized examination method to determine the extent of motor and sensory function loss after the spinal cord injury. So this is the international standards for neurological classification. So what are those standards are going to be? The standards are going to be like your sensory level, motor level, On the basis of that, you should be in a position to define the neurological level and whether the injury is complete or incomplete. So these are the major components incorporated in international standards for neurological classification of spinal cord injury assessment sheet, or they call it worksheet, we call it as assessment sheet. So all these things have been incorporated. Along with that, there are certain functions of S2 to S4 level, that is your perianal region sensation as well as voluntary anal contractions. So these are the standards. So if something is said to be like a standard, so there should have a specific way to define it. So if somebody says what is neurological level, it has a specific definition, and this is standard, universal, and well accepted. It is defined as the most caudal or distal segment or distal level of the spinal cord with normal motor function, normal sensory function on both, that is your left and right side of the body. Repeat, neurological level, that is the most caudal level of the spinal cord injury with normal motor as well as sensory function bilaterally, that is the right and left side of the body. Then what is motor level? That is referred to as the most caudal or distal segment of the spinal cord with intact or normal motor function. So if you call it normal motor function, that means it should be a grade 5 on minimal muscle testing. Sensory level, it is quite similar to that, similar to motor level. It is most caudal segment of the spinal cord with normal sensory function bilaterally. So if we say normal sensory function, that means on the sensory function grading, it has to be 2. It has a scale of 0, 1, and 2. So normal function is considered to be the 2. And motor function normal, that means on the minimal muscle testing, there has to be muscle power grade 5. I am sharing a picture of this assessment sheet. We call it assessment, they call it worksheet. This is a picture 1. Quite similar, I am sharing the second picture. If somebody has observed the changes into these 2 pictures, and then in a row, I am sharing the third picture. So basically, these are the 3 worksheets given by ASIA, that is American Spinal Injury Association. And basically, first, second, and third, they are the revised versions. There are other revised versions. So they are the revised versions. So the first one, what you can see in the screen, is version of 2000, year 2000. So it is called as a revision 2000. So if you are familiar with this picture or this worksheet, this is 20 years old. And if you see the sheet, this is somewhat like 5-year-old. So this is a revision 2015 sheet. And the third one, this is the most novel or recent sheet of 2019, which was actually accepted in the month of, I think, April 2019, and it was published probably in the month of October 2019. So there are certain amendments or changes incorporated in these revisions. So I'm not going to talk very much in detail about the previous revisions. We can have a comparison of last 2 revisions. So it is like revision of 2015 and revision of 2019, which is the most newer one, what we are going to use here onward. If you are not aware, like most of the undergraduate students say, we cannot expect from the undergraduate students, but this is expected from the postgraduate students as well as clinicians, academicians. Like we should know that the American Spinal Injury Association, this keeps on revising its worksheet on the basis of the inputs provided from the clinicians, various researches and advancements in the field of medicine. So there are revisions provided year by year. At times this is like after 4 years this revision was provided. We are very familiar with this impairment scale, that is ASIA impairment scale, also called as AIS, that is A stands for Asia, I stands for impairment, S stands for scale. We were talking about certain standards. So previously I had spoken about neurological level, motor level, sensory level. Three standards is a primary standards you can say, which has been incorporated in the Asia worksheet or standard assessment sheet. Then it defines the complete injury. So the definition of complete injury is having no sensory or motor function in the lowest sacral segment, that is your S4 and S5. What is important to be observed? Sensory and motor function of S4 and S5 are determined by anal sensation, that is the sensory function, and voluntary external anal sphincter contraction, that is also at times it is mentioned as EAC, voluntary anal contraction, EAC. So if one is a motor function and another one is your sensory function, if it is not present, then it is considered to be a complete injury. What is incomplete? It is classified as having motor and sensory function below the neurological level, including sensory or motor function at S4 and S5 level. Again, they are going to have the same function assessment. Motor function means voluntary anal contraction, and sensory function that includes your perianal region sensation. We can assess like light touch and pinprick sensation over this region. I have intentionally highlighted the definition of zone of partial preservation. I'm not going to talk about this because the definition, what is known to us till now, has been replaced. So if you have prepared, if you know this definition, kindly replace it because this definition has been replaced by the resource. Resource is your American Spinal Injury Association. The 2019 revision of the International Standards for Neurological Classification of Spinal Cord Injury. This was taken place at Honolulu in spring at 2019. The revision introduces two new concepts: the new taxonomy, first one is new taxonomy of documentation for non-spinal cord injury related impairments such as peripheral nerve lesions, pain, and defines the classification rules in the presence of such non-spinal cord injury conditions. So I'm going to talk about this revision or concept later. And the definition of zone of partial preservation has been changed, and now it can be used in some cases of incomplete injuries. Incomplete injuries, जैसे हमको पता है कि like if you follow Asia impairment scale, incomplete injuries are B, C, and D are the incomplete injuries. So now this can be incorporated in incomplete injuries also, with the absence of motor function or sensory function in the most product segments. Based on the feedbacks from the clinicians, there is an increasing number of patients with pre-existing or concomitant or associated musculoskeletal, neurological, or problems which have an impact on examination or following this worksheet or assessment sheet. Such problem includes chronic peripheral nerve injuries, burn, acute chronic pain, age-related musculoskeletal weakness. So if the patient who are existing problems like this, chronic or peripheral nerve injuries, fractures, burn, there are certain considerations into the work revision. In a previous revision, 5 asterisks was foreseen, or it was actually in fashion for the cases. So cases kya the? All those cases where the full muscle strength is not achieved, but the examiner thinks that it would be achieved if the non-SCI conditions was not present. So non-SCI conditions, मैंने बताया कि these conditions are like peripheral nerve injuries, fractures, pain, musculoskeletal conditions. So अगर ये non-SCI conditions did not persist in my patient, the patient would have scored like motor function, or patient would have achieved the motor strength of 5. So this used to be denoted with the 5 asterisks. So it was the assumption from the examiner considering the non-SCI conditions. However, this approach was having a drawback that it has been reserved for the motor function only. एक drawback ये था कि खाली motor function, the only motor function was actually considered, and the actual examination score is lost unless the examiner explicitly documents it in the comment box. So I have highlighted that comment box. This is present with the revision 2011, 2013, 2015. लेकिन 2000 का जो revision था, उसमें जो है ये कमेंट बॉक्स नहीं हुआ करता था. So onto this comment box, the examiner needs to put the comment onto that asterisk, with the asterisk having the score or certain considerations why your patient could not achieve score 5 of muscle strength. So there is to mention over here on the comment box. To overcome this limitation, general asterisk concept has been introduced where the abnormal examination score can be tagged with an asterisk to indicate that a non-SCI condition impacts the examination results. So here in the newer revision, you can see motor function as well as sensory, both the functions have been incorporated for the special consideration with the asterisk sign. This general asterisk concept is applicable to the motor as well as sensory function independent of level of occurrence, that is above at the level or below the level or sensory or motor level. The use of 5 with the asterisk sign is not recommended anymore. I repeat, the use of 5 with the asterisk sign where it was hypothetical from the examiners with the consideration of non-SCI conditions having the pre-existing peripheral nerve injuries, pain, fractures. तो उसमें एग्जामिनर जो होता था वो अज्यूम करता था कि अगर ये नहीं होता तो my patient would have achieved the maximum strength. So this consideration has been removed. Instead, the actual examination score should be documented and it should be tagged with asterisks. As such, for the motor strength, asterisks can be applied to motor score from 0 to 4. And for NT, that is not testable. And for this can be applied to the sensory function also up to the 0 and 1, and for NT also. They have very exclusively mentioned into the revision that ongoing clinical studies where the 5 with the asterisk is currently being used can continue with their studies using the same consideration. But if you're starting with your research studies using your Asia impairment scale or using your Asia international standards for neurological classification, now here onward, like after 2019 revision, this is not recommended to go ahead anymore with this consideration or hypothetical consideration for non-SCI condition. Zone of partial preservation, ZPP, is defined, the definition has been refined, and ZPP represents important piece of information for the characterization of patient's neurological status as well as recovery of the patient. Additionally, zone of partial preservation are among the most important predictors of neurological recovery. In year 2011 revision as well as 2015 update or revision, ZPP or zone of partial preservation were only defined for complete मतलब एशिया impairment scale का A grade जो होता है, grade A, it was defined with that only in these two revisions of 2011-2015, with no sensory function or sensory motor function in the most caudal segment of the sacral segments. Recording of zone of partial preservation only in cases with totally lost sensation, that is absent deep anal reflex, that is tap, absent light touch LT, absent pinprick in S4 and S5, lost sacral motor function, anal contraction, is not intuitive and restricts the value of ZPP for effective clinical communication to Asia A lesions only. Therefore, the ZPP rules were modified and are no longer based on the Asia impairment scale grade. The motor ZPP are now defined and should be documented in all cases, including patients with incomplete injuries with absent VAC, that is voluntary anal contraction. The zone of partial preservation on a given side is defined in the absence of sensory function in S4 and S5, that is your light touch and filtering on the sides, as long as deep anal pressure is not present. This means that in case with the patient having the present deep anal pressure, sensory ZPP on both sides are not defined and should not be noted. And sorry, it should be noted as not applicable. And in case with absent deep anal pressure, the sensory zone of partial preservation can be defined on the one side, assuming also absent LT and PP sensation as per the type of size, while it may not necessarily be applicable on the other side of if there is present light touch and thin break at the close line. This is what actually the new revised worksheet or assessment sheet looks like. We are quite familiar with this, and certain amendments or changes what has been done. I'm going to zoom it, and I have just highlighted those changes. And this is the second page, which is like quite familiar. Here only the change of definition of zone of partial preservation is there, as well as consideration for motor function grading. This has been changed with the new application of what has been recommended. This is quite like if somebody says, okay, how we are going to just read or have a basic look onto this assessment sheet or worksheet. Very easily you can see this. We have 5 key muscles for upper extremity onto the right side, 5 key muscles onto the left side of upper extremity. Similarly, 5 key muscles onto the bilateral lower extremity, 5 each side. So we have 20 key muscles with a minimum score 0, maximum score 5. So cumulative score is going to be like 0 is going to be the minimum score, and 100 is going to be the maximum score if the patient has fully recovered from the spinal cord injury. Similarly, we have 28 dermatomes for each side and each function. We are going to two sensory functions are assessed, that is for light touch and pinprick. So if you're testing two sensory functions onto the right side and two sensory functions onto the left side, there is going to have cumulative score of 224 and minimum score is going to be 0 because the highest score is 2 and lowest score is 0. Similarly, what standards they have provided to assess the neurological level, motor and sensory level. If you assess the sensory level, if you assess the motor level, on the basis of that, you can define the neurological level. This has been highlighted on the bottom of the sheet. And once your neurological level is defined, you can go ahead with whether to define this thing, whether the injury is complete or incomplete, whether anal voluntary contraction is present, whether the sensory sensations over the perianal region is present or not. So this is what actually I was talking about. You can see on the motor function scoring side scoring criteria, you can see 0, 1, 2, 3, and 4 having the asterisk sign, whereas the 5 has been deleted or removed from here. Similarly, in the sensory function, this has been incorporated now. Previously, the sensory function was not the part of this of special consideration, and this has not been incorporated, and the normal function with the asterisk sign for both motor and sensory function has been removed. So any considerations is not going to be there. The patient, hypothetically, the patient is having some pre-existing clinical conditions, and we can assume that if this wouldn't have been there, my patient would have achieved the maximum score of muscle strength. So this hypothetical assumption has been removed and taken off. If your patient is having some kind of associated non-spinal cord injury condition, and that the patient is not improving, they are not going to be considered as the completely recovered patient functionally. This is the second part of this scale where there are certain rules. We already know about the manual muscle testing system very nicely. Sensory grading, that is your 0, 1, and 2. And with the motor and sensory function, NT, that is not testable. And there are certain circumstances they have defined where you are supposed to mention it non-testable. That is, if the patient is having the immobilization or part is in immobilization, patient is having severe pain. So in certain circumstances, like patient is having amputation of the limb and fracture more than 50% of the normal range. So if we have certain considerations, you are going to mention it non-testable, not testable, that is NT. So with certain circumstances, if the patient is going to be evaluated, the part should not be examined. This is what your the most familiar picture with the spinal cord injury patients, that is your Asia impairment scale. This is quite descriptive now. A denotes the complete injury, where B, C, and D denotes the incomplete injury. B having the sensory incomplete, C and D having the motor incomplete injury. It defines the all type of injury, and E is the normal, means having the normal sensation as well as motor function with the standards. This also provides steps of classification. This helps determining the sensory level, determines helps in determining the motor level. On the basis of this sensory and motor level determination, you can determine the neurological level. And if the neurological level has been defined, you can go ahead with a determination for partial or complete injury. If it is a complete injury, then it should be mentioned as Asia impairment scale A. If it is incomplete injury, then this is going to be B, C, or D. So B is sensory incomplete, D and E is your motor incomplete. The same considerations are there. More than half of the key muscle having 3 or more muscle power. The same thing is there. Only change what is there in the point 6, that is your definition of zone of partial position. This has been incorporated in the revision 2009. Take home message, revision of 2019 to be adopted in the academic, clinical and research for here onward. Ongoing researches which was actually started prior to the revision need not to adopt these changes. This international standard for neurological classification of spinal cord injury is considered to be the most simplified way to examine with predetermined standards. So standards मैंने थोड़े से discuss किए भी, neurological level, motor function, sensory function, partial. You remember these basic definitions, you can talk onto spinal cord injury assessment with anybody anywhere. So that's all from my side. I thank you all for patiently listening me and sparing your valuable time for this knowledge sharing session. Thank you one more. I request organizing secretary to unmute our participants if they have some suggestions or anything they want to add on. If they want to share their knowledge onto this particular topic, we can keep the forum open for them.
Yes, sir. Thank you, sir. Thanks a lot for such a great session today. And it is really very difficult to cover such a big topic in such a short period of time. That spinal cord injury and its assessment itself, it is a very big deal. And this is actually a skill of a great resource person, a great teacher, that you have covered in such a short time all the things which has to be focused during assessment and all the associated comorbidities too. So really, sir, hats off to you. It was too much big to cover all these things in just a short time, and even in such a nice manner that we are able to understand everything. So now, I already shared the feedback form with the participants. I would like to request the participant so kindly fill out the feedback form, and if anybody has any query, they can ask. I'm just allowing you to unmute yourself. Am I audible, sir? Hello. Am I audible, sir?